Hello everyone and welcome back after this long interruption to our ECG course, and our lecture today is titled Ectopics in the ECG. Our ILO today is to learn how to recognize ectopics in ECG and how to differentiate atrial ectopics from ventricular ectopics, and to understand the special types of atrial and ventricular ectopics. So at first, what do we mean by ectopic beats? Ectopic beats include any single or group of beats arising from a single focus or multiple foci outside the SA node, either in the atrium or in the ventricle. Okay, so ectopic beats are beats arising outside the normal pacemaker of the heart, which is the SA node, so maybe in the atrium or in the ventricle. And so we have two types of ectopic beats, which are the atrial ectopics or supraventricular ectopics and the ventricular ectopics. Let's start with the atrial ectopics. Atrial ectopics, of course, as we know, includes like a premature beat that arise near to a preceding sinus beat. So there are two time intervals with each ectopic beat. A coupling interval, which is the interval preceding the ectopic beat between the sinus beat and the ectopic beat, and a compensatory pause, which is a longer time interval following the ectopic beat till the following sinus beat. So these two time intervals are very important to apply in case of ectopic beats, and we are going to use the same two terms also in ventricular ectopics. So coupling interval, time interval between sinus beat and ectopic beat, and the compensatory pause is a longer time interval between the ectopic beat and the following sinus beats. If we add the sum of the coupling interval and the compensatory pause, and then we divide them by the half, at that time we can find that the half of the sum of the compensatory pause and the coupling interval is the same as the RR interval. Okay, so RR interval in the rhythm or the underlying rhythm of this patient equal half of the sum of the coupling interval and the compensatory pause. So this is another example of premature atrial beat in which we can notice that the ectopic beat is nearer to the preceding sinus beat and further from the following sinus beat, and there is a compensatory pause following it. There is also another example of premature atrial ectopic, and there is an important thing that we should notice here in this case, that the P wave morphology in the PAC is different from the P wave morphology of the sinus rhythm. As you can see in the top image here, that there is a fixed morphology for the P wave in the sinus rhythm, but this ectopic beat have another morphology for the P wave, and this can be expected because here, of course, the origin of this atrial depolarization is not arising from the SA node, so it would have a different morphology and can have also a different axis according to its location. The same also in the bottom image, in which we can see that the P wave morphology is slightly different from the P wave morphology in the underlying rhythm of the patient, which is the sinus rhythm. So PEC is not only a beat that is coming earlier and nearer to the preceding sinus beat. No, it also shows different P wave morphology. So we can summarize the features of atrial ectopic. It is a premature beat as it comes earlier to the preceding sinus beat. It is followed by a compensatory pause. The P wave has a different morphology and or axis from the sinus rhythm, and sure, it would show the same complex morphology and axis as the sinus rhythm. So the P wave would be different, but the complex would show nearly the same morphology and the axis, because the ventricular depolarization proceeds downwards in the his Purkinje system through the AV node. So I should not expect to have a different complex morphology or axis. Let's now expect which is more expected with PEC. Do we expect to have longer PR interval with a PEC or shorter PR interval? Of course, we know that there is something called decremental properties of the AV node, which is a physiological phenomenon present in the AV node, that the higher the heart rate to which the AV node is subjected, at the time it would not conduct the whole impulse from the atrium to the ventricle, and the shorter the coupling interval subjected to which the AV node is subjected, at that time there would be more delay in the AV node, which is also a physiological phenomena, and this phenomena is aiming at protecting the ventricles from higher heart rates or extremely short coupling intervals. So here, the earlier the premature atrial impulse, at that time the more delay it would be subjected to in the AV node. And so in this case, I expect the PEC to show longer PR interval. And so for example here, we can expect that the PR interval with the PEC is longer than the PR interval in the underlying sinus rhythm. So this is what we can expect to see in PEC. Now sometimes we can hear the term of a non-conducted PEC. As we can see here, there is an arrow at the T wave, and this T wave is not the same morphology as the underlying T wave. It shows like there is another wave that is superimposed on the T wave, and this superimposed T wave is actually a PEC, but this PEC is, in contrast to the classic appearance that we usually see, is not conducted to the ventricles, and so there is no following complex. And so we should ask ourselves why. As we asked the question before, that which is more expected with PEC, longer PR interval or shorter PR interval, sometimes the PEC may be too early that it arrived at the absolute refractory period of the AV node. So here it would not be subjected to decremental properties, no, it would be rather subjected to non-conduction at all of the beat, because it is too early to be conducted through the AV node. And so in this case I would see P wave without a complex. So this is what we call non-conducted PEC, or sometimes it's called block PEC. Sometimes they are mistaken for a sinus pause, because as a first instance you may notice that I don't see any SA nodal activity for a pause or a certain duration, but if you focus on the T wave, you would see that the T wave here has a different morphology from the other T waves. So here it is a non-conductive PEC rather than a sinus pause, and this is very important before you diagnose sinus pause, to exclude non-conducted PEC. Let's now try to summarize some other terminologies related to the PEC. We know of course the atrial bigeminy. Atrial bigeminy, it means that after each sinus beat I would see a PEC. So I would have normal beat, then a PEC, and then a compensatory pause. Normal beat, PEC, and then a compensatory pause. So this is what we call atrial bigeminy, and this is the same example here in the below ECG. And as we see, the P wave morphology of the PEC is different from the P wave morphology of the sinus rhythm. So that's called atrial bigeminy, and of course on examination we could detect this as pulsus bigeminy, which can be detected by examination. Now we can see also the atrial trigeminy. Atrial trigeminy, it means that after each 2 sinus beats I would find a PEC. So each third beat in the patient's rhythm is a PEC, and we could see also different P wave morphology, short coupling interval, longer compensatory pause, and the same complex morphology and axis. So this is what we call atrial trigeminy. Every third beat is a PEC. We also have a terminology called quadrigeminy, which we can expect that quadrigeminy means that every 4th beat is a PEC. So here we could notice that there are 3 sinus beats, and then the 4th beat is a PEC. Then we have another terminology which we called atrial couplet. Atrial couplet here, as we can see in the blue and red arrows, that we can see here like there are 2 PECs coupled with each other. So after a sinus beat we have 2 earlier beats, they are very close to each other, and then they are followed by a compensatory pause. So here we can see that there is a pair of PECs, and this is what we call atrial couplet. And here we can see the same example here, that there are a pair of PECs, and so this pair of PECs is followed by a compensatory pause, so this is what we call atrial couplet. Now we can see this example here, in which there is a sinus rhythm, and after this I found a run of supraventricular ectopics, because here for example we could see about near 8 or 10 ectopic beats, which are of course supraventricular ectopics because of the narrow complex and normal complex axis. And this is a very common pattern that we see usually in Holter ECG, and we should call this run of supraventricular ectopics. We should not call this non-sustained SVT, because it is not an SVT and should not be considered an SVT and should not be dealt with as, for example, a candidate patient is candidate for ablation. No, it is just a run of supraventricular ectopics, which is sometimes a normal variance that can be seen in some patients, and when they are frequent, of course, they cause a lot of symptoms to the patient and may need rate controlling medications. So this is what we call run of supraventricular ectopics, as we can see here in this example. Here also we could see that there is a pattern that is slightly different and is characteristic at the same time, and so we should notice this in order to make a diagnosis. We could see here in this rhythm that there is at least 3 different P wave morphology and at least 3 different PR interval. From these black circles, of course, we could notice more than 3 different P wave morphology. So what can we call this? We can call this a type of rhythm called multifocal atrial tachycardia, and from its name it explains itself. Multifocal, it means that there are multiple foci for this rhythm. Atrial stands for that the atrium is the origin, as all the foci are in the atrium, and this explains why all the complex show normal morphology and axis. And tachycardia because the heart rate here is above 100. So this is what we call multifocal atrial tachycardia, which is an uncommon, not uncommon rhythm to see in your practice, especially in patients with COPD. And so this rhythm is important to characterize because sometimes it needs rate controlling medication if the patient is symptomatic. So here we can notice here from these arrows that there is at least 3 different PR morphology, at least 3 different PR intervals, so we can call this multifocal atrial tachycardia, or sometimes abbreviated as MAT. But if the same pattern exists and the heart rate is less than 100, of course, at the time, we cannot call it multifocal atrial tachycardia, we call it wandering atrial pacemaker. So the main difference between the multifocal atrial tachycardia and wandering atrial pacemaker is the heart rate, whether it is above 100 or below 100, but the other features are the same. Here we can see, for example, that there are at least 3 different morphologies for P waves and of course 3 different PR intervals. Now we have finished the supraventricular ectopics, and now we can move to the second part of our lectures, which is the ventricular ectopics. Regarding ventricular ectopic, as we can see here, that there is a bizarre shaped complex here in this ECG, which is characteristic to a lot of us in ECG. Of course, we can notice, as we explained before in the PVCs, that there is a short coupling interval between this ventricular ectopic and the preceding sinus beat, and then there is a longer compensatory pause following this PVC till the following sinus beat. So this is the same here in this ECG, that we can see short coupling interval between the preceding sinus beat and the PVC, and longer compensatory pause between the PVC and the following sinus beat. So we can summarize the features of ventricular ectopic to be premature beat followed by compensatory pause. So here are the same features as the atrial ectopic, but the difference here is that you would see a bizarre shaped complex with different morphology and or axis from the baseline rhythm, and this is something expected here because the focus is in the ventricle, and so the ventricular depolarization doesn't proceed through the His-Purkinje system as in the atrial ectopics, and so I could expect to see a wide complex because the ventricular depolarization is slower through the ventricular muscle fiber than in the His-Purkinje system. And so this explains why the complex show bizarre shape and show wide duration. And of course I would not see a preceding P wave because it is not originating from the atrium. So here I would not see a P wave before the complex, but sometimes it may be followed by a retrograde P wave due to retrograde AV nodal conduction. So don't be astonished if you saw a P wave following the PVC. This is retrograde atrial conduction, and at that time the P wave of course would be a retrograde P wave, so the axis would be reverted. It would be negative in the inferior leads and positive in AVR, as we explained before in the lecture of ECG axis. Of course, we have some terminologies related to PVCs, and of course these terminologies explain themselves as we explained before in the atrial bigeminy. For example, we have ventricular bigeminy, in which each second beat is a PVC, And so this patient, of course, also would have pulsus bigeminy, the same as the atrial bigeminy. So pulsus bigeminy means that this patient has either atrial bigeminy or ventricular bigeminy, and the ECG will differentiate it. So here in this ECG, we could see after each normal beat or sinus beat, there is a ventricular ectopic, and as we can see here, it shows wide complex P jar shaped, and there is no preceding P wave. Here, for example, another example for ventricular bigeminy in which each second beat is a PVC. Then we have another example, the ventricular trigeminy, in which each third beat is a ventricular ectopic. So we have two sinus beats followed by a ventricular ectopic, the same as we explained in the atrial trigeminy. Of course, we have much more terminologies related to PVCs that we need to explain here. Of course, we have something called monomorphic PVCs. What do we mean by monomorphic PVCs? As the term explains itself, monomorphic, it means that the PVCs arise from a single focus. So here we can see, for example, that the PVC shows the same morphology and the same axis, and we could determine this from the ECG strip. In order to decide whether they are monomorphic or not, you should look at the strip. So at the lower ECG strip, which is recorded from lay 2, we could see that the PVC shows nearly the same morphology and same axis, so they are monomorphic here in this example, indicating a single focus. But here in this example, on the contrary, we could see that there are at least two morphologies of PVCs. The first one shows a positive axis, and the second one shows a negative axis or a predominantly negative complex. So here I could expect from this short strip that there are at least two foci, and if I record a longer strip, I may see much more morphologies, and this indicates much more foci originating from which the PVCs are originating. So here we can call this multifocal PVCs, or sometimes we call them polymorphic PVCs, because there are different axes and or morphology indicating more than one focus. So the question now, does it matter clinically whether PVCs are monomorphic or polymorphic, or we can ask it in another way? Do I need to couple them in the ECG whether PVCs are monomorphic or polymorphic? Of course it is important and it is clinically relevant, because patients with monomorphic PVCs are candidates for ablation if the burden of the PVCs are high, whereas patients with polymorphic PVCs are not. And this of course makes sense, because in monomorphic PVCs there is just one focus that I try to define during the EP study in order to do radiofrequency ablation for it. But in polymorphic PVCs there are more than one focus, and so it makes the ablation procedure much more difficult. Sometimes it is impossible to eradicate all the foci, especially with higher number of foci. So monomorphic PVCs clears the way that if this patient is symptomatic with high PVC burden and developing complication from the PVC at the time, we may proceed for ablation. But in polymorphic PVCs it is not the same situation. And of course this drags us to the other question: what do we mean by PVC burden? We hear this terminology a lot in ECG. Of course, PVC burden is a terminology that you can read in the report of Holter ECG, not in the 12-lead surface ECG. In Holter ECG, PVC burden means the percentage of PVCs in relation to the total beats of the recording time. So for example, if you are recording Holter ECG in 24 hours, so I calculate the percentage of total PVCs in the 24 hours to the total beats during the 24-hour period, and so I can get a percentage of a PVC burden. And the higher the PVC burden, the higher the risk of developing like some sort of LV dysfunction that we call PVC-induced cardiomyopathy. Because the high burden of PVCs means that the ventricular depolarization during these ventricular ectopics would not proceed through the normal His-Purkinje system. It would start in one ventricle and proceed to the other ventricle through the ventricular muscle fibers. And this of course induces some sort of dyssynchrony inside the ventricles. So we call this precisely interventricular dyssynchrony during the PVCs. If there are few PVCs, as may occur in many of us and many normal individuals, it is not a big deal. But when the PVC burden is high, for example, patient having bigeminy or trigeminy all the time, in this case, these patients are at risk of developing PVC-induced cardiomyopathy, and so if the PVC are monomorphic at that time, we could proceed for ablation to protect the ventricles. Of course, we have a terminology of ventricular couplet, which we explained before in the supraventricular beats, and ventricular couplets means that we have a pair of PVCs coming together and then followed by a compensatory pause. This is what we call ventricular couplet, and this is the same example here in this ECG that we could see pairs of PVCs coming together. We have, of course, something called ventricular triplet. Ventricular triplet means that I have like 3 consecutive PVCs coming together and then they are followed by a compensatory pause. And ventricular triplet is a very important terminology to understand because it would be relevant to us when we would define the ventricular tachycardia. So we can call this pattern a ventricular triplet. So this drags us, of course, to the terminology or the definition of ventricular tachycardia. We have a type of ventricular tachycardia, mean non-sustained ventricular tachycardia, which means that there are at least 3 consecutive ventricular ectopic beats terminating spontaneously within less than 30 seconds. So if you could say 3 consecutive PVCs or much more at the time, you could define this as ventricular tachycardia. If it persists just for less than 30 seconds, it is non-sustained ventricular tachycardia. But if it persists for more than 30 seconds, at the time it is called sustained ventricular tachycardia. Sustained ventricular tachycardia usually needs cardioversion in order to be terminated. In few cases, it may terminate spontaneously after more than 30 seconds, but in most of the cases, if it persists more than 30 seconds, it would need cardioversion, and of course the preferred method at the time would be electrical cardioversion. We have another terminology which of course is terrifying to most of us, which is pulseless VT, which is a clinical term, not just an ECG term. It means that the patient has VT, but at the time there are no apical pulse, and so this patient is in cardiac arrest. So pulseless VT is a clinical term, not just an ECG term, because in the ECG you would see just ventricular tachycardia in the form of consecutive PVCs, but the patient has no apical pulse, and so in this condition the patient is gasping and there is no consciousness. We have another terminology called slow VT, in which we have sustained ventricular tachycardia, but at a relatively slow heart rate. It is tachycardia, but relatively slow in comparison to the classic patterns of VT. Usually the heart rate is between 101 to 149. So it is less than 150 beats per minute, for example, but of course it is still tachycardia because it is above 100 beats per minute. We have another terminology that sometimes is used but not very commonly used nowadays, which is a salvo, and salvo mean a run of consecutive 3 to 6 PVCs. So it is considered like non-sustained ventricular tachycardia, as we explained before, but in case of very short run of non-sustained ventricular tachycardia, sometimes we call this salvo, and it is written in some literature and some books. So ventricular triplet is considered a salvo and is considered as well a non-sustained ventricular tachycardia, and this is what I told you that we need to be focusing on the definition of ventricular triplet, because ventricular triplet is considered non-sustained ventricular tachycardia. So in order to try to classify a sustained ventricular rhythm, in which rhythm is composed of consecutive ventricular ectopic beat or consecutive PVCs. If the heart rate is less than 50 beats per minute, we call this escape idioventricular rhythm. If the heart rate is between 50 and 100 beats per minute, we call this accelerated idioventricular rhythm. Whereas if the heart rate is more than 100 beats per minute, of course it is ventricular tachycardia. So in all these types of rhythm, you would see that there are consecutive PVCs, but according to the heart rate, we could define it. Here we are not focusing now on escape idioventricular rhythm and ventricular tachycardia, because we are going to focus on them on the lectures of bradyarrhythmia and tachyarrhythmias respectively, but we are going to speak about accelerated idioventricular rhythm, or what we called AIVR. Accelerated idioventricular rhythm means that there is wide complex rhythm at a heart rate between 50 and 100 beats per minute, and so it is not escape rhythm because it is not bradycardic, and it is not ventricular tachycardia because the heart rate is less than 100 beats per minute. So heart rate here is between 50 and 100, and of course because this rhythm is originating entirely from the ventricles, not from the atrium, it shows complete AV dissociation, and this means that there is complete dissociation between the atrial activity and ventricular activity, because the P waves originate from the SA node, whereas the Y complex rhythm originate from the ventricle itself, from a focus inside the ventricle. It may be sometimes intermittent, so sometimes they appear for a few seconds and then they resolve, and may be sustained in some condition. And why some patient may develop accelerated interventricular rhythm? Of course, the most common cause is after reperfusion in case of myocardial infarction, especially in ST elevation myocardial infarction, and that's why it is very common to see this pattern during the PCI procedure or the primary PCI procedure after the artery is opened and there's chemistry flow, and sometimes you can see it in the CCU. And when you see this pattern, don't be terrified that the patient has ventricular tachycardia, because it is not tachycardia. The heart rate is less than 100. It is just accelerated ventricular rhythm, and it is the most specific reperfusion arrhythmia. So it is a good sign in patient with myocardial infarction. And in few cases it may be idiopathic, but the more common to see either in situations like after reperfusion, because it is reperfusion arrhythmia. So here in this example, we could see that the patient has wide complex rhythm. Of course, the heart rate is less than 100, so it is not tachycardia, and it's still above 50 beats per minute, so it is not escape ventricular rhythm. There is complete AV dissociation during this rhythm, as we could see that during sinus rhythm there is one-to-one AV relationship, but during the wide complex rhythm there is no AV relationship, no consistent AV relationship, so there is AV dissociation during these periods. So we can call this as the patient has intermittent accelerated idioventricular rhythm, or as an abbreviation, intermittent IVR. We have another terminology that we need to understand as well, which is the short coupled PVC. Short coupled PVC means that the PVC has a very short coupling interval, less than 300 milliseconds. So if I calculate the interval between the sinus beat and the PVC at the time, I could see that the coupling interval is less than 300, or sometimes it's defined as a PVC superimposed on the T wave. And this is a very clinically relevant information in the ECG, because there is something called the vulnerable period, or the R-on-T phenomena. At a period of relative refractory period, there is sometimes something called supernormal excitability. And in this period, if there is a superadded PVC arriving at this time, there may be risk of a certain type of malignant arrhythmia called Torsades de Pointes. For example, here we could notice that the PVC is very near to the preceding sinus beat in this example, as it is marked by the asterisk. We could see here also that the PVC is coming near to the sinus beat, and it is nearly superimposed on the top or the summit of the T wave. And here in this example, we could see that the PVCs are very close to the preceding sinus beat, that they are coming very near to the T wave during the duration of the transmural dispersion of repolarization, as we remember from the lectures of ECG terminologies. And why it is clinically relevant? Because in this period, if the PVCs are coming at short coupled interval, there is a risk of developing something called Torsades de Pointes, which is a type of ventricular tachycardia described as polymorphic VT with long QT interval. So if this patient has long QT interval and he had short coupled PVCs, there is a risk of Torsades de Pointes, which is a malignant arrhythmia that may degenerate into ventricular fibrillation, leading to sudden cardiac arrest and may culminate in sudden cardiac death. So you should pay attention to short coupled PVCs. Then there is another terminology that sometimes we read in literature called interpolated PVC. Interpolated PVC is, on the contrary to the classic pattern of PVC, it is a PVC that is located midway between two sinus beats without a compensatory pause. So if I can notice here, for example, that the PVC is coming on the middle of the RR interval, so it is not preceded by a short coupling interval and a longer compensatory pause, as we explained in the classic pattern of PVCs. No, they are midway between two sinus beats, and these are called interpolated PVC. So if you see this, don't be astonished or say that it is not a PVC, because it is not coming nearer to the preceding sinus beat and further from the following sinus beat. No, it is still a PVC, but a special type of PVC called interpolated PVC. And of course, we cannot end this lecture before speaking shortly about something called PVC localization, because if someone is specialized or interested in electrophysiology, of course he would read about this. How can we localize the focus for the PVC? And this is important during the ablation procedure if we decide that this patient may need ablation. Of course, the first thing to see is the axis in the inferior leads. If the PVCs are positive in the inferior leads, which is a very common situation for PVC, or the most common to see in PVCs, that they are positive in inferior leads, this means, according to the ECG axis, that they are coming from above and going downwards. So I could expect that they are coming from the outflow tract, which may be the right ventricular outflow tract or the left ventricular outflow tract. But if they are negative in the inferior leads, they are coming at another focus away from the outflow tract. So this is the first thing to look at. Then, in order to decide whether they are right ventricular or left ventricular, we look at the complex morphology. If it is near to the right bundle branch block morphology, so it is coming from the left ventricle, and this explains that if it is coming from the left ventricle, it would give a pattern of right bundle branch block. And if it shows left bundle branch block morphology, I could expect that it is coming from the right ventricle and going towards the left ventricle, and this could explain why it shows left bundle branch block. Of course, this is a very short and summarized way to decide a PVC localization, but of course, if anyone is specialized in cardiac electrophysiology, he would read a lot of details regarding PVC localization. The last thing to have in this lecture regarding PVC or PEC in this example, if you could see here, we could see that there is a wide complex here with bizarre shaped coming nearer to the preceding sinus beat and further from the following sinus beat. So what would we call this? Would we call this PVC, as most of the clinicians when they see this ECG would call this PVC, or call it a PEC? Of course, many of us would call this PVC, but if we look further, we could see that this PVC is preceded by a P wave, which is something strange, and we should not see this pattern with PVC, and it is not a coincidence that each PVC in this strip is preceded by a P wave. So this is not a PVC, it is a PEC despite the wide complex, but we can call this PEC with apparent conduction, because in this case the PEC came in the relative refractory period of the Hesper-Purkinje system, so it was not conducted smoothly without any delay. No, there was a problem in one of the bundle branches leading to a bundle branch block morphology, as we could see here that the PEC is conducted with right bundle branch block morphology, and we cannot call this PVCs because each ectopic beat is preceded by a P wave, as we could see here clearly in the strip of lead 2. So this is PEC with apparent conduction, and here it shows right bundle branch block apparency. And we could see in this example that it is very clear that it is PECs with apparent conduction, not PVCs. And we should ask ourselves, which is more common, the right bundle branch block morphology or apparency, or the left bundle branch block apparency? There is a fact that the right bundle branch has a longer absolute refractory period than the left bundle branch. So with very early PEC, the right bundle branch has longer time to recover from refractoriness than the left bundle branch, and so I could expect that the earlier the PEC, it would show apparency, and the more common pattern is to show right bundle branch block apparency because of the longer absolute refractory period in the right bundle branch than the left bundle branch, and so it is the more common pattern to see in PEC with apparent conduction. Now, at the end of our lecture, we can summarize what we understand now from this lecture. We understood today how to differentiate PECs from PVCs, and we understand as well how to differentiate PVCs from PEC with apparent conduction, as we show as the last slide in this lecture. And of course, we understood today specific types of ectopic beat and a lot of terminologies as couplets, triplets, bigeminy, trigeminy, quadrigeminy, non-conductive PEC, PEC with apparent conduction, multifocal atrial tachycardia versus wandering atrial pacemaker, interpolated PVC, monomorphic versus polymorphic PVCs, and we understood AIVR as well. And remember our take-home message today: An ectopic beat preceded by a P wave is mostly PEC, even if it shows white complex, and this we explained in the PEC with apparent conduction. And don't jump please to a diagnosis of sinus pause before you exclude non-conducted PEC by giving like more precise look on the T wave to show whether it is a superimposed P wave or not, because if it is a non-conducted PEC it is a physiological phenomena, but if it is a sinus pause, at that time we need to define its duration and whether they are causing symptoms or not. Thank you very much for your listening, and in the next lecture we are going to start to discuss rhythm disorder, and we are going to start with bradyarrhythmia. Thank you.